Let me go check one thing really quickly, and I'll be right back.
Ours was like.
Yeah, and he's like, just one of the, yeah, with less buttons. No, I don't want any of this, weird leaves coming from my house. It's like, it's like room. Yeah. Well, it's all black.
I'll be able to record your audio. And then you can still talk. Okay, I'll be able to support you. Yeah, so we can choose which we are going to.
Oh, it'd be great.
One of our chiefs last year actually matched them very young. And this year, so it's you know? All right, should we get started? All right, we're gonna get started. Sorry for the slight delay. We have no mic today due to a blown speaker, so we will be speaking loudly. So we'd like to thank Dr. Seethala for coming to join us today.
Oh, thank you.
Dr. Seethala,
Instead of speakers.
thank you. Dr. Seethala grew up in India and completed his heart failure fellowship at Scripps Clinic in San Diego. As primary author, he has published close to 30 papers and abstracts. Dr. Seethala lives in Boise with his wife and 7-year-old son. As a family, they love to hike, ski, and bike. We'd like to thank him for joining us here at the Boise VA and turn the time over to him.
Oh, thank you very much. Really, it's a great honor to be here. And, that's my 7-year-old son when he's a baby. And I was doing my heart failure fellowship. And every day morning, I used to wake up and go to work. And he used to come with a book like this to me to the car parking lot. So that's a fun part. And disclosures, I speak on the behalf of BMS for mavacamten, which is an cardiac myosin inhibitor drug for hypertrophic cardiomyopathy. And I'm not going to touch anything related to that drug today because we are not talking about HCM. And today I'm trying to tell you guys and explain you guys what did I learn in 3 years of cardiology and 1 year of heart failure fellowship in 1 hour. That's the goal of it. So if we know all these trials, like next 2 slides are all the trials that made what the heart failure is. Truly, if you know all these trials back and forth, you don't need a heart failure fellowship. You are really good. So we will go back at the end of the session to all these trials. What is truly a heart failure means? That's a bigger question comes. And is it an elevated BNP or is it a low EF? What is heart failure means? It's a clinical syndrome where your heart is unable to meet the metabolic needs of the body. That's the place where Dr. Carvalho comes and helped me at St. Alphonsus to do the CPETs and help me to find out whether the patient's heart is helping the metabolic needs of the body. At the end of the day, it is a good muscle, sends oxygen to every part of the body. There is no emotion to it. There is no relation to Valentine's Day. It's just a piece of muscle sending blood to the body. And every institution has their own definition for a heart failure. And heart failure is a complex clinical syndrome with the symptoms and signs that results from any structural or functional impairment of ventricular filling or ejection of the blood. So then, why do we care about heart failure? Truly. Obviously, patient's symptoms are one. And number 2 is how much it is costing for our healthcare industry. In 2012, AHA estimated that there will be like $3,600 direct dollars cost to the patient and $1,700. And the amount of money that you guys are paying as a tax roughly is $70 billion per year by 2030, just to a heart failure diagnosis in the hospitals. And in United States, there is 5.7 million adults have been diagnosed with heart failure, and it costs like $39.2 billion to $60 billion as of today. And in the fiscal year of 2020, 83% of Medicare participating hospitals were penalized. If any patient gets a readmission for the hospital for a heart failure, like Medicare will penalize them not to pay the second admission, and then they will start cutting the payments to the hospitals. And we all talk about hey, this drug companies take money and all that stuff. But then where most of the heart failure money goes? Mostly goes to inpatient care, 49%. And your medication goes only for 8% of the care. And then outpatient goes to around 28% of the time. So inpatient costs a lot. And then how do we classify the heart failure? We can classify it based on the etiology. We can classify it based on the ejection fraction. Ejection fraction, if it is less than 40%, it is a heart failure with reduced ejection fraction. If it is greater than 50%, it is heart failure with preserved ejection fraction. In between, mid-range, because this is middle. And based on the etiology, we can classify it as an ischemic cardiomyopathy, non-ischemic cardiomyopathy, genetic cardiomyopathy. This is the place where left ventricular non-compaction and hemochromatosis comes, and peripartum cardiomyopathy, stress-induced cardiomyopathy, and idiopathic dilated cardiomyopathy. But once you have a reduced ejection fraction, the guideline treatment is same for all of these. That's the weird fact. And then stages, if you guys come around with us in our heart failure division, or if you guys go anywhere who have a heart failure program, they will start talking about stage A, B, C, and D. So obviously, what is stage A? Means they are at a higher risk. That is your diabetes patients, your hypertension patients. Those are your stage A patients. And stage B means they are already having a structural damage. That means there is a low EF, but they are compensated. They don't have any symptoms of heart failure. That's the reason why I went back in the beginning saying it's a clinical diagnosis. It is not based on the EF. And stage C is if you have a low EF and along with the symptoms, that is your stage C. And stage D is irrespective of what I do, patient is declining. And I'm thinking at that moment in time, transplants, mechanical hearts, inoprobes, palliative care, and that is your stage D cardiomyopathy. And the symptoms of classification, that is NYHA classification. Truly, this classification started even before I was born, and that's the history of the medicine is. And NYHA class 1 is limitations, NYHA class 4 means they are having shortness of breath at rest. And 2 and 3, it's in between. Why it is important, am I right? My NYHA classification might be different from yours. And patients subject to interpretation of the symptoms is different. So a guy like, I have a patient who throws the bales and he declined from throwing 10 bales to 1 bale. And for me, even throwing a 1 bale is, I can't do it. And he can do it. Yeah, is he an NYHA class 1? No, because he dropped from 10 bales all the way to 1. So his symptoms were pretty significant. That's the importance of NYHA classification. It is mostly subjective phenomena. And then we can talk about new onset heart failure, resolution of the symptoms, and improved ejection fraction, worsening of ejection fraction as other etiologies.
Can I pause 1 second? I need to make it so the slides are seen on Teams.
Okay.
So I apologize to the people on Teams that we're not seeing this.
That's a beautiful place. Well, I want to be there.
Sorry.
No worries. So then everyone talk about ejection fraction, and that is ingrained into our brains day in, day out. Heart failure with preserved ejection fraction, who have an NYHA class 4 symptoms, has the same mortality as heart failure with reduced ejection fraction and NYHA class 4 symptoms. So it is an important in prognostication, but it is not the only thing. And I also want to let you know that ejection fraction depends on the reader. There are a couple of trials that were done truly in Brigham, and they gave the same echocardiograms to 10 cardiologists, and they gave same echocardiograms, and everyone read a different ejection fraction on the patients. And then they trained them and tried to see whether they will be unified again. No, they did not unify again. There is 5 to 7% discrepancy in the ejection fraction. So whenever we are reporting, don't stick to the number, stick to the range of 5%. That's always a good rule of thumb, because people are always stick to that 42 to 41, 42 to 40. No, as long as it's between 40 to 45, it's the same. And it also depends on what are the other factors at that moment in time. Is he preload or is it afterload? And what is the inotropy? How excited the patient is. If I have patient popped long back and walked here, his ejection fraction appears to be low. And so that's the importance of ejection fraction. It should be interpreted with a caution. And it helps us to classify, like as I mentioned, heart failure with reduced ejection fraction versus preserved ejection fraction. And it helps us to prognosticate. If you have a low EF, your low EF is continue to come down. That is going to help you to prognosticate, because you cannot give an LVAD to a patient who has an ejection fraction of 50%. You need to have a 25% or below ejection fraction. And it determines preload, afterload, and inotropy. Those are the 3 important things that determines your ejection fraction. If patient is on dobutamine, if you have an ejection fraction of 30%, we need to write it on the chart saying that this patient has ejection fraction on dobutamine, because it's a cause to inotrope, or norepinephrine or epinephrine, and the ejection fraction is normal. Maybe it's secondary to the inotropy from those drugs. And how often do we need to do an echo? That's a bigger question. Each time when there is a clinical decompensation, that's the guidelines. Each time when there is a decompensation, you could consider doing an echocardiogram. If patient is stable, no symptoms, you don't need an echocardiogram every 1 year or every 6 months. And then the next question comes is physical exam. Like what are the signs of heart failure? Is it rails or is it like S3 gallop? Or is it edema, or is it orthopnea and TND? Which one is the most sensitive marker? And what are the physical exam findings that has the best reliability? That would be your JVP exam. Whereas you can have it in the pulmonary problems, and you can have ascites from your liver cirrhosis. But JVP is quite sensitive. It is going to be wrong, make you wrong about your wedge pressure, only maybe 1/3 of the cases. And then this is called Lynn-Stevenson classification. This is one of the most important prognostication that we can have, warm and dry and cold and dry. So if you are cold and wet, your mortality is quite high. These are the people, they need my attention quickly. If a patient is hot and dry, they are compensated. So we are okay with their mortality a little bit. And then JVP exam, how do we do a JVP exam? We just make them at 30 to 45 degrees angle, and we'll check from manubrium sterni to the peak of it. And that's what your JVP exam. It has a sensitivity of 65 and 64%. And so with all you things that I said, this is the most reliable marker. That's the sensitivity and the specificity of it. And then physical exam and biomarkers. What is the role of a proportional pulse pressure? If you guys come around with us, you guys will see, like, I talk about the pulse pressure and what is the proportional pulse pressure is. Your diastolic blood pressure is your systemic vascular resistance. Your systolic pressure will be determined by how much is your ejection is. And if that is coming down and down, then your heart is getting weaker and weaker. And that's what the proportional pulse pressure is. And higher the proportional pulse pressure, poor the outcomes, and 25% is around the curvilinear marker. If you are having a 25% or below the proportional pulse pressure, you are in trouble. And then we all have an arterial line and in the ICU, and you can do the Valsalva maneuver when the patient is having. And if you are going to do the Valsalva maneuver, and if their blood pressure comes down and doesn't go back up, that is a very bad prognostic sign for your heart failure, because their ejection fraction is going. Now, their heart is not squeezing enough of blood out. And BNP and utility. And BNP is a great marker. Like, truly the name of the trial is BNP, breathing not properly. That's the way that they came into the trial. And to differentiate between respiratory causes and heart causes. And it is a great marker. You can do it as an outpatient to see whether you are getting response. And you can do it as each time when the patient comes into the hospital to see whether it is higher than the previous one or lower than the previous one. And that's important. But to track it as an inpatient marker, there is no data to support. So day-to-day changes of your diuretic management based on a BNP is not recommended. And cardiopulmonary exercise test, this is the most important test that we have for transplants and LVADs. And you have an MVO2 less than 14. If you are not on beta blocker, if you are on beta blocker, it's less than 12, then your mortality rate goes higher. And that's the reason why we choose that 14. We didn't come up with just a magic number. When that trial was done, then the mortality rate for a transplant is around 15%. And when you have an MVO2 less than 14, then your mortality rate is 1 year mortality rate is 20%. So that's the reason why we choose that 14 as a number. And heart rate response is an important thing. Heart rate recovery is also an important thing when we are measuring cardiopulmonary exercise test or a stress test. If you are having a great heart rate recovery, it's great. If you don't have a great heart rate recovery, that's a bad sign. And VEV-CO2 slope is important, particularly when you don't have a respiratory exchange ratio greater than 1, BEV/CO2 slope can tell us whether there is a higher mortality or not. That's the place 35 came into the role. And then initially I presented the slides of all the trials that we have. What are we changing? Initially, we used to have a mechanical way of treating the heart failure. Then we came into the neurohormonal modulation method of it. What are the neurohormonal modulation we are trying to change? This is the RAS system. I think it is bugging me since I'm a resident or like a medical student. Like, everyone make me to read about RAS system back and forth. And I thought I can get away from it, and I came into heart failure, and it made my life more miserable. So obviously, now you guys are seeing where we are targeting renin is your kernel or anis kernel. And then AC inhibitors are your bread and butter, and angiotensin receptors are going to be, and aldosterone receptor blockers, that is your spironolactone, eplerenone, and nowadays it's called phentermine too, based on phenoxysterol. Then you got the newest kid on the block is called Entresto. Even though it's not new, it's like as old as my son is, if not more than. Like 2012 is the first time paper came in. Why the truly neprilysin inhibitor or sacubitril was tried as an hypertensive drug. It increased the risk of angioedema. That's the reason why it failed. And then it came into the market within a combination within ACE ARBs to decrease the mortality. That is your paradigm HF trial. And it came into market and it just crushed everything. And the reason for that is when you have an AC inhibitor, you are going to have a higher bradykinin. That's the reason why they combined the pill with sacubitril with ARBs to make things better. So you don't get a bradykinin high level and you don't get an angioedema. That's what the slide is saying. Why do we want to increase neprilysin? God-given gift. I'm not supposed to say it. Maybe not. And God-given gift to human body or a physiological gift to human body is neprilysin. It is the best afterload reduction agent. It's best inotropic agent. It's the best preload agent. If you are going to talk to any patient who has an atrial fibrillation, they say, oh, I'm going to pee more at night all the time. Why? When you are having heart failure, when you lay flat, you will have a wall stress that goes higher, and you will have a higher neprilysin, and that makes you pee more. That's the reason why they have more trouble, like a urination at night. And then AC inhibitors. Again, another God-given gift to human body is the snakes. Your first captopril came from a snake. And that's the snake where they manufactured it from. That's the snake, And then it clearly showed the mortality benefit, and it decreased the mortality by roughly 20 to 25%, 5% mortality reduction. That's a great response. So they came into the market. And the next, one other thing that I want to let you know is if you carefully look at it, most of the people in this are NYHA class 2 to 4. Initial trials included all the stage 4, NYHA class 4 symptom patients. AC inhibitors and beta blockers in those trials, they have an NYHA class 4 symptom patients. So ARNI is your paradigm HF trial, and NYHA class 4, less than 1% of the patients. There is a new trial that came in if you are having a stage D cardiomyopathy, and it might not change the outcome. There is a new trial came up, and it said no, it doesn't change the outcome if you have a stage D cardiomyopathy. And the composite endpoint is 21.8% versus 26.5%. So obviously it won. And then beta blockers and mechanism of action, it is going to decrease the heart rate, it decreases the myocardial oxygen recovery, and it changes the beta 2 to beta 3 receptors change in your myocardial cells. And that's the reason why they decrease the mortality. And beta blockers first trial is CBIS trial. Why did I mention about CBIS trial as a first trial? Because most of the people forgot about bisoprolol as a great heart failure drug. That's one of the first drugs that showed a mortality benefit. Everyone also comfortable of using metoprolol and carvedilol and forgot about bisoprolol. Bisoprolol is one of the first drugs that showed a mortality benefit. That is CBIS trial for you guys. And mortality benefit is significantly better, 12% versus 17%. Again, MHA class 3 and 4. They did not include MHA class 2. So these are sick people. And then COMET trial is your Carver law. And why are we talking about metoprolol succinate versus metoprolol tartrate? In heart failure management, we always want to give a metoprolol succinate, no for metoprolol tartrate. Why does it matter? Based on this trial. And they tried metoprolol tartrate versus Carver law. Metoprolol tartrate has a mortality 34 to 40%. So metoprolol tartrate did not decrease the mortality. That's the reason why metoprolol succinate, because metoprolol succinate trial is a positive trial, long acting. And then, does the dose matter? Like what dose of beta blocker? Like, can I sprinkle like a 3.125 of Carver and be okay with it? And then the answer comes as a MOCA trial. And they tried with Carver placebo versus 6.25 versus 12.5 versus 25. Mortality difference, p-value less than 0.01 right across. So the dose matters. We always try to go for a max tolerated doses. That is if you are going to use carvedilol, that should be around 25 milligrams POBID. If you are using metoprolol succinate, try to go up to 100 to 150 of minimum dose kind of. And if you follow the guidelines, that is 200 milligrams. But most of the people will have lots of side effects at 200 milligrams. If they can tolerate, great, go to 200 milligrams. And then MRA, spironolactone, how did it came in? So it is very strong, LVE of less than 35%, and stable dose of diuresis. They tried spironolactone, the same thing. We changed the aldosterone pathway, and it decreased the mortality. And relative risk is 0.7%, and risk of hospitalization is 35% less. From now onwards, it will start changing the trials from mortality gradually to heart failure hospitalizations. And then SGLT2 inhibitors, that is your emperor reduced trial, and this is empagliflozin, and most of the people know as the Jardians, and dapagliflozin, most of the people know as the Farxiga. If you look at it, it changed the heart failure hospitalization mostly. Primary endpoint is a composite endpoint. It is heart failure hospitalization and mortality. Primary endpoint was strongly met, but when they separated, it is mostly separated by the heart failure hospitalization than mortality. But you cannot separate it so clearly. That's the reason why it came in. As I mentioned to you, the cost of hospitalization is quite high. So that's the reason why it incorporated into guideline medical management so quickly. And then we forgot about this drug called Bible. The first ever done trial is combination of hydralazine and isodine in heart failure against alpha blocker. And it didn't change the mortality. Then they looked at it. African Americans have a mortality benefit. Then they ran a trial called the AHAP trial to see whether it decreases the mortality in African Americans. It clearly showed heart failure hospitalization decreased by 33%, mortality rate 10.2% versus 6.2%. It decreases the mortality rate. So particularly if you have an African American patient who is on GDMT, and if they are still having heart failure or blood pressure that can tolerate, ideal combination is a good one. The reason for that is hypertension in African Americans is different, and moreover, the people could agree and disagree, and there is a back and forth comes on this. AC inhibitors and ARBs are not as effective in African Americans when compared to Caucasians. There is a mixed data goes back and forth on every time, and their blood pressure is quite nitric oxide sensitive. That's the reason why this trial is successful in African Americans. Then vericiguat Victoria trial, if somebody watched in the news, they are coming back with it. My wife sent me a text saying that, oh, is beta blockers is bad in a woman. And because it's presented in CNN, there is a new data came in. And yes, we know that beta blockers are not good in HFpEF. We know that for a long time. Don't worry, don't tell me again. We don't need a CNN to tell. And digoxin, again, if you guys are watching like recent European thing, it is going back and forth about it. And there is only one point I could make a difference is digoxin that we use in America is just different from the digitoxin they tried in the trial that is presented at ESC. The reason for that is that digitoxin can be metabolized by even liver. We don't have that digitoxin in America. So this is purely cleared by renal. So that's the only major difference between those trials. But if you are choosing to use digoxin, that is your concentration should be around 0.9 to 1.1. That's a place where you have a best mortality benefit without increasing mortality. And then we come with a question of, do we need to start all these pills at one time? Do we need to use quadruple therapy or can I go one by one? Do I need to start with a gradual dose of everything? The strong HF trial gave a hint of it. That is quadruple therapy is better than going on one drug max dose, then add the next dose, next drug kind of a thing. Quadruple therapy, start at lower dose and then go for it. I did not include the new trial called Cathedral trial that came out. So what happens if a heart failure recovers? Do we want to withdraw the drug? Can we stop all the drugs? That's a bigger question comes. There are two trials that were done because my talk initially, I should not divulge into it, but I did. And Fred HF trial, if you have a recovered ejection fraction, if you stop the drug, nearly 40% of the people have a drop in ejection fraction again. Cathedral, what they did in that trial is they withdrew all the drugs. And in Cathedral trial, they changed all the quadruple therapy to a single therapy called Carolina. And that is a positive trial. That tells us that you could be able to try to change it to single drug or Carolina. And if we are going to use that trial, just go for a Carolina. Don't go for it. And then device therapies, AICD. And AICD clearly we know that it decreases the mortality by cardioverting the patients or defibrillating the patient if they go to VT and VR. And there are MADIC trials, and that is the reason why AICDs come into the market, and they're really good. One thing, AICD never improve the ejection fraction. AICDs never decrease the heart failure symptoms, with an exception of CRT, cardiac resynchronization therapy. That is our 3-lead pacemakers. That can improve the ejection fraction. That can decrease the heart failure symptoms, but not AICD per se. And then mortality benefit. Mortality benefit versus like a symptomatic benefit that I was talking there. And then the new kid on the block is microclip. Everyone see about microclip, we hear about it. Two things it does. Number one, it does decrease the mortality rate. And number two is it can give you some time to bridge this guy to an advanced heart failure therapy. If you are having a low EF patient, functional MR, and if you clip them, if they don't recover, it gives you enough of time to make him a candidate for advanced heart failure therapies. That's the reason MT is an important part of the heart failure therapies. And most of the things that we need to think about is average age in these trials. And population is aging, and heart failure is becoming more common because we are having more and more mature people. And the defibrillator trials, the max age in those trials is 74. If I'm going to tell, I'm going to extrapolate the data from a defibrillator, do we want to give a defibrillator to 85 or 90-year-old male? There is no trial that showed a mortality benefit. That's the place where it comes as a shared decision making. I'm not against a electrophysiologist. I'm not, and all I care about is shared decision making. What the patient knows about what we know as a trial. And if a patient knows that we don't have any data to support it or refuse it, as long as they know whatever they want to make decisions, I'm okay with it. Then we will change it, our topics. This is truly what my subspecialty is, cardiogenic shock. The first part of it, most of the people can take care of. And the second part of it, that's the place where I needed to sit for 1 year of heart failure day in, day out and learn about everything. And finally, I'm here. So what is the cardiogenic shock? That's the best question. Is it increase in lactic acid, or is it increase drop in the blood pressure? What is the cardiogenic shock definition? Every trial that has their own definition of cardiogenic shock. And the one IABP trial, they used a map of 70. In your most of the ICUs, they don't use a map of 70. They use a map of 60 to 65 is the common thing. And shock trial, they used a drop of systolic blood pressure by greater than 30 points to 40 points, 40 mmHg, or there is a systolic blood pressure less than 90 or requiring vasopressors greater than 30 minutes. That's the trial definition of it. And the ESC guidelines also use the systolic blood pressure less than 90. And the NIH trial also used the same thing, less than 90, greater than 30 minutes is the trial definition. Evidence of end organ damage is always a part of it. And where do we start and where do we end? We all see the cardiogenic shock. Everyone can realize. It's the same thing as we go through medical student, intern, resident, cardiology attending, all these things, am I right? It's the same thing. Everyone can realize extreme. That is, lactic acid is 10 and the patient is hypotensive and requiring 3 or 4 presses. Everyone can realize. Mortality is extremely high. The sweet spot is stage C and stage B, where they are entering into cardiogenic shock, where you could act quickly and then you can change the management quickly. If you are going to treat it in stage B and stage C, the mortality is significantly better when compared to stage D and E. And patient at stage A, neither hypotension nor tachycardia nor hypotension, and study definitions are. And stage B, there is a hypotension without hypoperfusion, low blood pressure, but their kidney is making urine and your LFTs are not going up. And stage C is hypoperfusion without deterioration. What it means is they are not continue to get worse and worse and worse, and their blood pressure is dropping, and your urine is used to be 50 cc per hour, now it is 30, and now 20, now 10, kind of a thing. And stage D, hypoperfusion with the deterioration, not refractory shock. What it means is by the time I started the patient on vasopressors and dobutamine and melatonin, still having the problem. And stage E is hypoperfusion with deterioration and refractory shock. I think everyone knows that at that moment in time, we need to think about balloon pumps or Impella or ECMO and things like that. And the mortality is 10% with the stage A and 70% with stage E. That's dramatic change in the mortality. So that's the place we realizing it when the patient is entering into the cardiogenic shock is really important. That's the place where Dr. Lynn Stevenson's classification of 2x2 classification, cold extremities, and still having a dryness, that's a beautiful spot. You can start treating, and then they can get better. And if you are going to wait them to have a fluid overload, and they have a cold extremities, your mortality is quite high. She showed this staging of the classes that came in 2015. Lynn Stevenson wrote her paper in 1980s or 1990s, and she's smart. And this is the same thing presenting in a different fashion, in a tabular fashion. And by stage E, you are having lactic acid greater than 5 millimoles per liter. That's European definition, I think. We don't use millimoles, we'll use milligrams per deciliter here. That is your 1.5. And then these are all the trials that were done on mechanical circulatory support devices in shock patients. Till now, just if you guys want me to take one take-home point, all these trials are negative. There is only one trial that is also I can sit and debate multiple times and a long time. That is Impella in acute MI that came as a positive trial. That's called the danger trial that came in less than 1 year back. And that's also they took the trial almost to doing 7 years in between. They changed the definition of shock multiple times. And there is like no difference between Danish versus Germany and UK mortality rate. But all these devices are helpful if you are going to find them early in the part of the shock. If you are waiting till late and late, the likelihood of mortality is going to be higher and higher. If you have a lactic acid of 5 or 6, me trying to reverse it back, if it is pure cardiogenic shock, is really hard. If you are having lactic acid of 1.5 and I have a cold extremities, start either melatonin or dobutamine, you might be able to reverse it quickly. And if the patient is like, having talking to you and falling asleep, talking to you, falling asleep, talking to you like a sentence, falling asleep, that's a sign that he is having cerebral hypoperfusion. And that's one of the classic signs for having cerebral hypoperfusion. And when your heart is functioning a little bit, he's getting a little bit blood to the brain, he's talking to you. And like after like having it sometime, it comes down, he will fall asleep and talk to you again. And then we need to think about, like till now, I'm talking about left side of the heart. Everyone cares about left side of the heart. What happened to right side? And we need 4 chambers. Like, there is one thing that my RV has to support to the lungs. As I mentioned to you in the beginning, lung is the place where you get an oxygenation, and blood is the place where you get oxygen. Heart is just a mechanism to send it out. It's like an engine, but everything has to work fine. And if I have high pressures in the lung, RV is going to go down. How do we define RV failure? That is your right atrial pressure that tells you how much is your RV failure is. And if you have a CVP to wedge ratio greater than 0.86, that is predominantly your RV shock, then LV shock. And if your RA pressure is normal and if your wedge pressure is quite high, then you are going to have like, LV shock. That's a place where pure support of LV is going to be okay. And in acute MI, PAPI is like, is your PS systolic minus diastolic by right atrial pressure. What it means is how much your RV is pumping out divided by how much it left it in your RA. That's what the truly PAPI is. It's one of the most important prognostic factor for me in LVAD world. Before I implant an LVAD, I will check what the patient's PAPI is. If PAPI is low, if I implant an LVAD, I know that these patients are going to get into trouble from RV very soon. So why does it matter, am I right? Then we will know which side of the heart we need to support. Do I need to support just the right side? Or do I need to just support left side? Or do I need to support both sides? And till now, these are the mechanisms that we have. And number 1 is our intra-aortic balloon pump. Number 2 is your impeller. You can have an impeller CP and impeller 5.5. And that is a typo because it's 5.0 used to be. And it changed 3 years back to 5.5. Now there is no 5.0, it's only 5.5, impeller 5.5. And then you have your tandem heart, and that supports your 4 to 5 liters. And then you have an ECMO, I can support from 4 to 10 liters. Most important thing, VA ECMO. If you have a low EF, you are going to increase LV afterload. You always need to think about a vent. What it means is, how can you get rid of the blood that is staying in the LV? Your heart is weak. You are having higher afterload from my VA ECMO cannula, and the blood is going back into the body. Your heart cannot pump. If it can't pump, it is going to stay in the LV. If it stays in the LV, you can have a blood thrombus, and people will die from shock, like a stroke. So that's the reason when you are having a very weak heart, you always need to worry about it. If you have a very strong heart, you will worry about north-south syndrome. What it means is you're having a VA ECMO, your heart is competing and pushing the blood against the VA ECMO, and your right side of the right cerebral artery is going to get it from your heart and the lungs. And VA ECMO sends only to the left side. That's the reason why we check the blood pressure on both right radial line and left radial line to figure it out how much is the cerebral perfusion is going on those guys. That's north-south syndrome. So you need to know about how do we want to manage those two things very carefully. And the tandem heart, it avoids that, like, quote unquote venting mechanism. And nowadays, people are doing a thing called LAVA, which is left atrial septal ventilator. What it means is they go through the groin and like an RA, puncture the septum and leave the ECMO catheter there. That's called LAVA. Historically, the tandem heart is that. The problem with the tandem heart is you can't use the oxygenator that much. With the LAVA, I can use the oxygenator. That's the main difference. Also, we need to think, do we need to have an oxygenator? What it means is how is their lungs are doing, or I'm supporting just a heart. If I'm just supporting a heart, I don't need to worry too much. Do I need to support a heart and lung? That's a different ballgame that we are talking. And number 3 is Impella 55 is a great device. It can supply almost like 5 to 6 liters of the blood. It is as good as your VA ECMO is. Main problem, we do not support the lung. If you are having pulmonary edema badly, and if your lungs are bad, you cannot use Impella. You can use only VA ECMO, because at that moment in time, I need to support both lungs and the heart. And intra-aortic balloon pump, it's a great device. If I want to list somebody for a transplant, I will use it because that gets them status very good. And it supports only 0.5 to 1 liter and not much. But it is a great device if you are having very high SVR. If you are like, it's easy to remove from the body. If you are trying to figure it out, like, okay, where this is going to go, where this patient is going to go, I don't know. Is he a druggie or is he not a druggie? And if you are debating it, maybe it's the chip shot that we can try. Try to give you enough of time to think about it. But try not to exchange devices from one to other, like, balloon pump to Impella CP to VA ECMO, because each time when you are poking, you are going to increase the vascular complications. And the likelihood of the patient dying because you are taking them to cath lab is high. That's from the patient perspective. And from the hospital perspective, I need to sit in the hospital administration, like, maybe 10 times why I'm spending so much money on it. Because each of them costs a lot. And VA Impella 5 costs like roughly 40,000 or 50,000 minimum. That's just nothing else other than the device itself, not like an operating cost, nothing else. And that's the reason why we need to have a careful selection of the patients. And do we want to do, just forgive me, I'm not doing any age discrimination or anything like that, but do we want to do in a 95-year-old person, like, Impella CPs and 55s, then we need to have palliative care consult first. Then we can think about MCS first. Next. Palliative care people are my best friends, truly, like, because they help me to guide lots of issues. And then, like, this is the best slide for my residents and fellows. And because we all try to, like, learn lots of things, like, during our residency, saying that, oh, my attending likes norepinephrine, my attending likes vasopressin, my attending like this. So we all learn the same thing. Like, as I mentioned to you, no one knows about bisoprolol because none of the attending starts using it. Once your attending starts using it, you will know about bisoprolol too. And in ICU, everyone uses norepinephrine. When it comes to me, I use like a dobutamine. And truly, this happened during my fellowship. And one attending will come and like start milrinone. The next attending will come and start dobutamine. I truly don't know the rationality for it. Then I started looking for why they do what they do. What are they trying to change? Then I found the answer for it. Whenever you are starting an inotrope on a patient, what are the things that you are trying to change? Are you trying to change SVR? Are you changing cardiac output? And do you want to increase SVR or decrease SVR? Do you want to affect the PVR? And those are the important decisions that has to go through your mind. And if you are trying to just increase your SVR, phenylephrine is your bread. That is your septic shock patient. I don't have anything else. I just want to increase the blood pressure. I gave enough of fluid. I just need to increase it. Phenylephrine is your bet. There is only one cardiology. No, there are two cardiology scenarios. I try to use phenylephrine. One, hypertrophic cardiomyopathy. Do not use dobutamine on those guys. You will get into trouble. And another one is the PAH patients, because your RV is going to have filling both in systole and diastole because RCA, because it's the difference between systolic pressure and diastolic pressure that determines your perfusion. On left side, during your systole, there is no pressure difference between your left coronary artery systolic pressure and LV systolic pressure. So you don't get any perfusion there. You get it only during diastole. But right side, your RCA systolic pressure is always higher than your RV and diastolic pressure, RV systolic pressure. That's the time that I want to use it. And if you are using a melronone, if you want to drop a PVR, melronone is your best bet. And dobutamine is going to drop your SVR and PVR. Everyone thinks dobutamine will increase the blood pressure, but truly, if you look at carefully follow it, it drops your diastolic blood pressure. And melronone is a great drop of your blood pressure. So don't try to start it at 0.125 if your blood pressure is around hundreds and see where they are, then go up and up to see whether your inotropy is going to counteract your drop in the blood pressure. Moreover, if you are having a drop in the blood pressure, and if you have a weak heart, you will perfuse more because you don't need to work harder. And epinephrine, it does everything. And then the bigger question comes is renal perfusion, renal dose of dopamine and everything. Inotropic assisted diuresis is a negative trial right across, right all the bat. Melronone, dobutamine, norepinephrine, everything is a negative trial. If anything that came a little bit positive trial is a ROSE trial. If you want to use a dopamine, that is your 2 to 3 milligrams per deciliter. And then this is the place where we need to think about, when to think about advanced heart failure therapies. Do I want to use LVAD as a bridge to transplant, or do I want to use ECMO as a bridge to recovery, or do I want to take LVAD as a destination therapy? When I say LVAD and ECMO interchangeably, if you guys is he getting confused? No, I'm not getting confused because the classification is same for me. When I'm using ECMO, am I taking it to a bridge to decision? Or am I taking him to bridge to transplant? Am I taking him to a bridge to LVAD? If I'm using LVAD, I also need to think about what is my final outcome with this guy is. If it is a 75-year-old guy, I'm trying to do it as a destination therapy. If I'm doing it in 30 and 40-year-old guy, I'm trying to use it as a bridge to transplant. And the indication for advanced heart failure therapies, LVEF less than 30%, and isolated RV failure. The RVC is an indication for transplant, but we don't do LVADs on those guys because we are not supporting RV. And non-operable severe valve abnormalities and non-operable severe congenital abnormalities, we need to look for them and we need to see whether they are a candidate for VAD or transplant and what are the other contraindications. But these are the classic indications for advanced heart failure therapies. And severe impairment of function exercise capacity and MVO to less than 12 ml per kg per minute. This came, I copied this from European guidelines. That's the reason why we said millimoles. And criteria, and we can all modify this criteria based on ventricular arrhythmias. If you are having a patient who's having a ventricular arrhythmias and an IV amiodarone and requiring shots, then everything will be modified because then we are upgrading his status in the transplant. Then we need to think about, do I need to take him to an LVAD to get rid of his ventricular arrhythmias? And mnemonic for referral, this is when do we think the patient is going to require for advanced heart failure therapies? I need help. That's the way that they came. People are quite creative. They came up with, I need help. And it is like an LVEF is dropping down further and further, and also having edema. I'm going to gradually increase the dose of diuretics and NYHA class 4 symptoms. And if you are seeing progressively worsening renal failure, or patient is requiring multiple shocks, those are the signs that we need to think about referral for advanced heart failure therapies. What are the 3 options? Because I have only 5 minutes, I will skip fast here. advanced heart failure therapy options. When I see a patient, these are the only 4 things that goes into my mind. Is he a candidate for OHT? Is he a candidate for LVAD? Or is he a candidate for total artificial heart? Or am I going for a palliative care with palliative inotrope? When I say palliative care, I can still do palliative inotropes on that. And this is a complex statement saying like, what goes through my mind. Truly, if I see the Intermax 3 and 4, that's the best survival rate for your LVAD. Intermax 1 and 2 means like, they are sicker and sicker, mortality rate goes higher and higher. And, as I mentioned to you, LVAD there's a destination therapy versus like, bridge to transplant. And orthotopic heart transplantation, still. LVAD is the reason why most of the heart failure programs are out in the entire United States. But still, the gold standard is transplant. That's the best shot that you can give for the patient, if you want it. The reason for that is, if you are surviving 1 year after the first year mortality rate is roughly around 15 to 20%. If you survive the first year, you surviving next 10 years is close to 80%. LVAD, I cannot say that. And HeartMate 3 LVAD survival rate after 10 years is roughly 50 to 60%. And what are the most important contraindications? If your BMI is greater than 35 is one of the contraindication. And if the patient is having current or alcohol usage or drug usage, that's a contraindication for transplant, not to an LVAD. Sometimes people change a lot. We might want to give them a shot by an LVAD as a bridge to transplant. And there are some people who don't change. There is a possibility too. I gave an LVAD to a patient because he promised that he will change. Then he went home and took his met and he burned the dry line. And we need to restitch the dry line and we need to restart the LVAD. That happens. Then we will give them hey, this is not acceptable. We just need to have a pep talk to these guys once a while. Oh, every transplant program has this. Every LVAD program has this patients once a, at least 1 or 2 of them. And LVAD indications, the same thing. If you are having RV failure, do not give an LVAD because it supports only LV. It doesn't support RV. Do not give an LVAD if you have an RV failure. And contraindications: age, renal failure, RV failure. Renal failure means on dialysis. And multi-organ dysfunction, liver cirrhosis, because if you are having RV failure, you push your blood into the liver, congestive hepatopathy. So sometimes in order to prove it that liver cirrhosis is not from a heart failure, I need to do the biopsy, liver biopsy, to see whether how much is liver cirrhosis, how much it is fibrosis. And contraindication for anticoagulation and lack of family supports are the contraindications for an LVAD. And the indications for total artificial heart, if you have both right side and left side of the problem, take the entire heart out. Just give it a total artificial heart. But the contraindication for it, it's a bridge to transplant. It is not a destination therapy. So what it means is you need to think that this guy is going to get a transplant. And then heart failure is a teamwork, truly. Sometimes I take the credit for all of the great work done by my team down there. But it's purely a teamwork. I just go there and tell them, hey, I want this. And they do it for me. And I truly don't know lots of times how it is happening. But these are the people that work with it, like myself and Dr. Kasparovich. Victoria is my APP. If anything that need to be done at my program, that's going to be Jenny Elling. And our VAD coordinators are Jessica and Morgan. They know VAD patients more than their family members sometimes. They know every fine details of their LVAD patients. And then Greta Barrick and Jessica Pickle and Hannah Bristol are my transplant coordinators. They are know they're all transplant patients. They just come and talk to me once a while and say oh, I'm having this problem. I just put that's easy to fix. Thank you. And next time we will talk about pH, whenever that is. Whenever Oh, thank you. Yes,
Autonomia. What's IST? Is that ever going to be classified as heart failure?
We do treat it like, particularly in amyloid. And once I started treating cardiac amyloidosis, I started learning more about this abnormal, and I started using powder pigment more often. And I started using droxidopa more often. And powder pigment is a great good which your understanding symptoms very well. And it does work beautifully in cardiac amyloidosis. And I started using it more often.
Because sometimes insurance will only cover certain drugs
Yeah.
if there's a congestive heart failure diagnosis. So some of these patients with autonomia, their hearts are abnormal and it's like, but they're not covered.
And what I can do sometimes is like if they are having heart failure symptoms like anything with their heart failure is the diagnosis. And but try to treat it to get this abnormal,
Yeah.
completely different path. But side of treatment is a $4 and it's quite frequently done. And droxidopa is a very hard to cover. But it's a great drug which you can trust.
Thank you.
That's purely from my amyloid document. Very complicated.
Thank you for coming.
Thank you.
And, so I,
Oh, we are agreeing.